We will discuss the radiation toxicity. We have already discussed the radiotherapy of head and neck. Now we'll discuss radiation toxicity. In that, there are two terms: short-term toxicity or long-term. Acute autotoxicity, what all it involves: tiredness. Recovery of the pre-treatment level uh, uh, can take up to 6 months. Dryness of the mouth or xerostomia can develop during the first week of treatment. Radiation damage to the plasma membrane of the secretory granules. Radiation damage to the plasma membrane of the secretory granules. So remember this. Plasma membrane of the parotid and submandibular salivary gland flow rates fall rapidly to less than 20%. Watery and mucous components of saliva are not affected equally. The initial general dryness give way to increasing thick sticky saliva beyond the fourth week, which also affects the basically gut pH and all. Mucositis. So we'll discuss mycositis. Develop from the third week of treatment onwards and increase in severity according to the volume irradiated and total dose. Reaction progresses from erythema to the patch mucositis, characterized by the white patches of fibrinous exudate on an erythematous base. Two confluent mucositis were the exudate patches coalesce. Skin erythema increases from the third week onwards. Progress is from faint erythema to bringed erythema in moist desquamation. फिर देखिए acute toxicity management, antibacterial pastilles. Acute toxicity measurement what management, what we give: antibacterial pastilles, antiseptic mouthwash, water-based mouthwash, biotin, anti-inflammatory mouthwash like benzyldiamine, hydrochloride, diphen. If there is a candida infection, we give fluconazole. Analgesics: increase strength soluble aspirin or paracetamol, or soluble cocodamol 3500 to morphine sulfate solution or amphoterol in increasing doses. There is something called magic solution, which is given in Tata Memorial. That also can be given. Feeding via percutaneous endoscopic gastrostomy (PEG). Percutaneous endoscopic gastrostomy should be considered for all patients at risk of severe and prolonged mucositis. Zinc can be given. Oral balanced saliva replacement gel. Trials of submandibular gland transfer have shown some reduction in xerostomia by swinging the contralateral salivary gland on its pedicle and relocating it to a more anterior position. The radioprotecting drug amifostine has been investigated as a means of reducing the incidence of xerostomia and mucositis. Amifostine needs to be given intravenously daily prior to the radiotherapy. This is important. Skin care: maintain skin hydration either with hydrochloride dressing or copious aqueous cream. So acute toxicity recovery, this is important. So time to recover after completion of a degree of recovery expected at this erythema of skin. It takes 7 to 10 days, and complete recovery is there. Thought dry and more sensitive to the sun for the year following. 1 year, it will be more sensitive to the sun. Mucositis, mild mucositis, it takes 10 to 14 days for the recovery, and recovery is complete. Mucositis severe. Recovery may not begin until 2 to 3 weeks after treatment completion, then take up 4 to 8 weeks to regain normal swallowing. Mostly complete from mucosa can remain more sensitive. Less than or equal to 5 patients may remain PEG dependent. Test 6 to 8 weeks. Test 6 to 8 weeks total in most cases. So dry mouth, sticky saliva resolved within 2 to 3 weeks. Recovery of dry mouth from 3 to 24 months. If saliva gland irradiations, unilateral recovery to the within 80 to 90 hours. If salivary gland irradiation, bilateral recovery limited, particularly with doses more than 30 grays. Lethargy 6 months. Lethargy can remain up to 6 months, and recovery is already complete. Late toxicity. So we will discuss the late toxicity. It is dose related and predictable. Loss of enamel from direct irradiation, osteoradionecrosis may be associated with dental extractions, which are therefore best avoided where possible. The risk is reduced in those without teeth. So risk is reduced in those without teeth. Trismus is related to the dose of radiotherapy received by the received by the masseter and pterygoid muscle. So optic nerve. Let's discuss effect of radiotherapy on the optic nerve. Contralateral optic pathway to be kept within safe limits. This optimizes tumor control and limits the worst consequence to unilateral blindness. Spinal cord. Lhermitte sign 6 weeks to 6 months after radiotherapy, tingling or electric shock sensations down the spine into the back of the legs and aggravated by neck rotation due to transient demyelination as a result of temporary loss of oligodendrogalia. It recovers spontaneously after a period of months. Carotid artery stenosis risk is greater in those with a history of hypertension and smoking. With a history of hypertension and smoking, hypothyroidism, cataract, laryngeal, pinna, nose, cartilage necrosis. So this is very serious side effect. Hope I have done the full justice to the chapter. If you are having any query, you can contact me on the WhatsApp using the link or number provided.